Good day, everyone. Welcome to the Association of State and Territorial Health Officials PHAB Domain 6 webinar series. Today's conference is being recorded. At this time, I'd like to turn the conference over to Ms. Jamie Ishcomer, Senior Analyst of Quality Improvement and Performance Management. Please go ahead, ma'am.
Thank you, and thank you all for joining us. On behalf of the Association of State and Territorial Health Officials, aka ASCO, I would like to thank you for participating in today's webinar entitled Introduction to Public Health Laws. This is the first of a three-part webinar series ASCO is hosting on the Public Health Accreditation Board's Domain 6, Public Health Laws. My name is Jamie Ishcomer. I'm a Senior Analyst of Quality Improvement and Performance Management at ASCO and will be monitoring today's session. For those that may not know or be familiar with ASCO, ASCO is the national nonprofit organization representing public health agencies in the United States, U.S. territories, freely associated states, and the District of Columbia, and the over 100,000 public health professionals these agencies employ. ASCO's vision is a state and territorial health agencies advancing health equity and optimal health for all. Our mission is to support, equip, and advocate for state and territorial health officials in their work of advancing the public's health and well-being. Today's webinar is brought to you through funding and partnership between ASCO and the Centers for Disease Control and Prevention, Center for State, Tribal, Local, and Territorial Support, proposed. The content of this webinar are those of the authors and do not necessarily represent the official position or endorsement by the Centers for Disease Control and Prevention. Before we begin, I want to quickly go over a few logistics for today's webinar. First, all lines are muted and will remain muted for the remainder of the call. We will have time for questions at the end of the webinar. Questions can be entered into the chat box. And if the question is for a specific individual, we ask that you please indicate who that question is for. If you are sharing a conference room or computer with others, please use the chat box to provide each of the person's name, organization, and email address to ensure they receive future announcements regarding the webinar series. There will be a brief evaluation at the conclusion of this webinar. Please take a few minutes to complete this, as will help ASCO ensure our own continuous quality improvement. And finally, today's materials, including the recording, will be available within 1 week of the event. All registered attendees will receive an email with a slide deck at the inclusion of the webinar, as well as a notification when the recording has been posted. Here's a quick look at what you can expect from today's webinar. I will quickly introduce each of our presenters before turning it over to them. You'll first hear an introduction to PHAB Domain 6, Public Health Laws from the Public Health Accreditation Board, followed by the Centers for Disease Control Public Health Law Program, who will be providing an introduction to public health laws for state health agencies. And finally, we'll hear from an accredited health department, the Utah Department of Public Health, on how they were able to organize and meet PHAB's Domain 6 requirements. And again, we will have time for questions at the end of all three presentations. And as a reminder, this is the first part of a three-part webinar series focused on PHAB Domain 6. So first up, our first presenter is Robyn Wilcox, the Chief Program Officer for the Public Health Accreditation Board, or PHAB. Robyn manages the implementation of the accreditation process for public health departments. This includes assisting health departments through the process, as well as training health departments and site reviewers and managing volunteer site reviewers. Robyn also leads the revisions of the standards and measures, modifications to the accreditation process, and the development of the reaccreditation process and requirements. She joined PHAB in August of 2007. Robyn's work at PHAB follows a career of leadership and innovation in a variety of settings. Robyn worked in the Pennsylvania Department of Health for 15 years in positions that included the Director of the Office of Policy Planning and Evaluation and Deputy Secretary for Community Health. As Vice President of the Pennsylvania Institute for Healthy Communities, she worked in communities to bring together public health, healthcare, and community resources to build communities that create health. As the Executive Director of a 5-county health policy and planning agency in southern New Jersey, she directed community health assessments, community research, health service planning, community and provider consensus development, and consumer involvement in health planning and policy development. Robyn has a master's in public administration from the Pennsylvania State University. Following Robyn, we'll hear from Matthew Penn. Matthew Penn is the Director of the CDC Office for State, Tribal, Local, and Territorial Support Public Health Law Program. In his role As director, he leads a team of legal analysts responsible for the agency's efforts in legal epidemiology and workforce development to support the understanding and use of law as a public health tool at the state, tribal, local, and territorial levels. Mr. Penn and colleagues have been shaping new directions for the public health law community with research and publications including Better Health Faster, the 5 Essential Public Health Law Services, Policy of Surveillance, a vital public health practice comes of age, and a transdisciplinary approach to public health law, the emerging practice of legal epidemiology. Prior to entering federal service, he was the staff attorney serving South Carolina's Department of Health and Environmental Control as an advising and litigation attorney with extensive experience in the areas of emergency preparedness, disease control, and environmental health. And from the Utah Department of Health, we have Dr. Mark Babbit and Nikki Campbell. Dr. Babbit is the Deputy Director of the Utah Department of Health, as well as the Medical Director for Health Clinics of Utah Salt Lake City and Ogden Clinics. He received his medical degree from the University of California School of Medicine in San Francisco, California, and he is a board certified in family medicine. Dr. Babbit had a lengthy and distinguished career working for the U.S. Public Health Service and National Health Service Corps from 1975 to 1994. During that time, he worked in rural family medicine in the medically underserved community in Northern California as a chief medical officer for the NHSC in Rockville, Maryland, and then as a regional clinical coordinator in Denver, Colorado. Dr. Babbit joined the Utah Department of Health in 2005 as a division director of the Division of Health Systems Improvement from 2005 to 2009, and then transitioned into division director of the Division of Family Health and Preparedness in 2009. He currently is the deputy director of the Utah Department of Health. And we also have Nikki Campbell, who is the health educator at the Utah Department of Health. She attended the University of Utah, where she majored in health promotion and education. Nikki worked as a co-lead alongside the Utah Legislative Liaison for accreditation of Domain 6. Without further ado, I'd like to turn it over to our first presenter, Robyn Wilcox from PHAB. Thank you.
Thank you so much, Jamie. Before we get into Domain 6 and the details of what it requires, I'd like to spend just a moment on the Public Health Accreditation Board and what we do and who we are. We are the accrediting organization that accredits governmental public health departments. So just the way there's an accrediting organization for schools, we are the accrediting organizations for public health departments, and that's all we accredit. Accreditation in general, no matter who's doing it, is the assessment of an organization against some set of nationally recognized standards, and then documentation submitted by the organization that wants to be accredited, documentation of their conformity with those standards, and then in most cases, and certainly in PHAB's case, it's a peer review. So we have a cadre of PHAB-trained volunteers who have experience in governmental public health do the actual reviews of the information that's submitted by the health departments. And then after the assessment is done, accreditation issues some kind of recognition of achievement for accreditation. PHAB accredits health departments for a period of 5 years. Our very first health departments that were accredited in March 2013, so just about 5 years ago. And in the last 5 years, now we have 220 accredited health departments. There are 2 local health departments that went through the review process and did not achieve accreditation. They are not accredited. Of those 220 accredited health departments, there are 31 state health departments that are accredited and another 9 in the process. We hold that information when health departments are in the process confidentially, so we can't say who is in the process. But the 31 state health departments that are accredited are listed on the Public Health Accreditation Board website. So why do we do this? Why do health departments seek accreditation, and why does PHAB do accreditation? Our goal is to advance the quality and performance of health departments, state, local, tribal, and territorial health departments, to improve the quality and performance of those health departments. So our standards are both, they're not the gold standards and they're not the floor, the minimum standards. They're somewhere in between. The standards are developed so that They are achievable by health departments, but there's also a stretch. There's a push in our standards because we do want to ultimately transform public health and public health departments. The standards and the measures that health departments are assessed against are organized within these groupings of 12. It's the 10 essential public health services. The first 10 are the 10 essential public health services. And then we added a group around administration and management and another group of governing entity. So we call our groups of standards domains. So these are the 12 domains that the standards are organized in. And you'll see domain 6 is enforced public health laws, and obviously that's what we will be talking about today. Before we get into the overview of the what's in Domain 6, there are a couple important overarching points that I want to make about the standards and measures in Domain 6. That even though Domain 6 is called Enforce Laws, the enforcement part of it is really a small part of the standards and measures in Domain 6. In addition to the enforcement part of it, we talk about the need for public health expertise to influence laws and regulations. So it's not just about enforcing laws, but that public health officials and public health workers have expertise in how those laws will impact on public health, and it's about sharing that expertise. And then communication and health education, that both the public and those whom are regulated need to understand the laws and what's in them and why they're there. And collaboration is a very important part really throughout all of the PHAB standards and measures, and also in Domain 6 of health departments collaborating with other entities in the community that may be responsible for enforcement of laws, but also other health departments. And a second major point is that while the title of the domain is laws, we talk about enforcing laws, the health department's documentation can relate to state statutes, rules and regulations, executive orders, case laws, and codes. Just as an example, we use the words laws in Domain 6 just as shorthand for any kind of document that holds the authority of a law, an enforceable law. A third important point to keep in mind is that the standards and measures recognize that in many, many health departments, enforcement of laws is not a responsibility of the health department. And we state that in the standards and measures. But we also know that someone does the enforcement. So even if the health department doesn't do the enforcement, the health department, in submitting documentation to us for assessment, the health department is responsible to share information and follow up as appropriate with those health departments or organizations that are responsible for enforcement. Another organization may do the enforcement, but then they should be sharing that information with the health department so the health department can see patterns and trends and can engage in health education as appropriate with the population. And the fourth and final overarching important point is that we encourage health departments to use the broader definition of health. So when you're looking at laws or regulations and policies, we encourage health departments not just to look at the usual suspects of, for example, state laws around vaping or state laws around quarantining folks or the immunization laws, but to think broader in terms of health equity and discrimination and racism, housing, transportation. They all impact on the population's health. Environmental health and environmental health racism and voting rights and civic engagement. Exclusionary zoning that has a negative or positive impact on public health and the educational system. So we're not just talking about the traditional public health laws, but a broader definition of health of all kinds of laws and policies and regulations that can impact on the public's health. So let's talk a little bit about what's in Domain 6. And I know that it's very easy when you're looking at the standards and measures and you're working on coming up with documentation, it's very easy to get lost in the weeds, sort of, what does this relate to, and how does this pertain to, and how is this standard different than that standard? But I do want to impress upon you that there is a logic to how the standards and measures are laid out and organized, and there is a flow. So for Domain 6, the first standard is review the existing laws and work with governing entities and elected appointed officials to update as needed. So this gets at the expertise that the Public Health Department has about the impact of laws on the public's health. Standard 6.2 is educate individuals and organizations on the meaning, purpose, and benefit of public health laws. So this gets to that issue that I mentioned of making sure that the public and those that are regulated understand what the law is and why it's there and the benefit of them. And the third standard in the domain starts to get at that health enforcement, that the health department is responsible for conducting and monitoring the enforcement activities, and as I said, if they don't conduct them, at least monitoring them to coordinate notification of violations among the appropriate agencies. So let's drill down into Standard 6.1 just a little bit. There are a couple measures in 6.1. The first is to review the laws. So we want health departments to actually review the laws, and in particular the laws' impact on health equity, to use some kind of a standard methodology when they do review laws, and then to collaborate with other levels of health departments that the law may impact on it. And then the second piece of that measure is that the health department has to have access to legal counsel. I think every state health department probably has a legal counsel on staff, but if you don't, you just have to have access to them, and the health department needs to show how they access legal counsel when they need some legal advice related to this domain. And then the second part of this standard is to communicate needed changes. So you've done the review of the laws, you've accessed legal counsel as you've reviewed those laws, and now you have some opinions about it. We want to see some written recommendations, some written documentation that the health department has provided recommendations to officials concerning either new laws that are being considered or amendments to current laws and the public health impact of those. The next standard is to educate individuals and organizations. And the first measure under that is that you, as a health department, the health department needs to know and apply the laws. So the first element of that is that the health department staff need to be trained in the laws that are specific to their job. If they're working in an area around enforcement, or even if it's not around enforcement, maybe it's a health equity kind of an issue, they need to know what the laws are related to that. And they need to ensure consistent application of the laws. So if they apply the laws, they need some internal process to make sure that they're applied consistently. Or if they work with others who apply the laws, they need to monitor and communicate with them to ensure that they're applied consistently. And the next element of this standard is that the public has access to information about the requirements. So the public understands what the laws are and the permits and licenses. And the third is that the regulated entities also need to have that kind of information about what they need to do to be in compliance. And the third standard has a few more measures in it. It's a little bit more detailed around enforcement. So the standards and measures, the first measure wants to know who does have the authority for these enforcement, and if it's the health department or someone else. And we need some documentation of that, whether it's a law or rules and reg or whatever gives the health department or the other organization the authority for enforcement actions. And then the standards and measures ask for, well, we want to see some procedures and protocols for these enforcement activities. And if there's somebody else's, then the health department can submit those procedures and protocols that the other organization uses. We want to see some kind of regular inspection, that there's a regularity to it. So whether that's a protocol or an algorithm, but but schedules for the inspections, that they're not just inspected only when there are complaints or only when the health department gets around to it or the other organization, but that there's a schedule. And then we want to see some evidence that the inspections actually took place that met those schedules, and that there were reports of those inspections and that there was follow-up and final disposition of the inspection. The third measure in that standard asks for evidence that the procedures were followed, both for routine inspections and for emergencies, that there were actions taken in response to complaints, and that there were communications regarding the complaint and the compliance to both the public and to the regulated organization. And then the health department, again, even though it may not actually do the enforcement, it's important that they track what's happening so that they can identify patterns and trends. And so the standards and measures asks for some kind of an annual review of complaints and enforcements and compliance with laws and regulations, so that issues that come up over and over again, the health department can take whatever actions are appropriate, whether that's educate those regulated or educate the public, or just provide public health information and education, and then to do the debriefings and evaluations for process improvements, so that they're looking at it from an annual perspective to identify patterns and trends, and then they're looking at how they can improve the process. And the next one, the next measure is coordinated notification of violations to the public and coordinated sharing of information among agencies. So some local health departments, just for example, publish a list of restaurant inspections and the results of those restaurant inspections weekly in the local newspaper. So there has to be some evidence that the violations and the information that was gained through this whole process is shared with the public, that it's also shared with the regulated, the organizations that are regulated, that there's some interagency communication. Even if the health department is responsible for the enforcement, we need to see that they share that information with other agencies that may have a role in follow-up or public education, and then notification that the protocol has been implemented. So that's a quick, very high-level, quick overview of the standards and the measures in Domain 6, just so that you have a good sense of both what's in there, but also how the logic flows in terms of what the standards and measures are asking for. And with that, I'll turn it back over to Jamie.
Thank you so much, Robyn, for that high-level overview of Domain 6 public health laws for public health accreditation. Now I'm going to go ahead and turn it over to our second presenter, Matthew Penn from the CDC, who will discuss Public Health Law 101, an introduction to public health law for state public health agencies for public health accreditation. Matthew, take it away.
Great, thank you so much, and hello everyone, and thank you so much for dialing in for today's webinar. In sort of getting ready for the webinar and doing some planning, we thought, well, if we're going to talk about Domain 6 and enforcement of public health laws, maybe we'll start off talking a little bit about what we mean by public health laws, put them in context to a larger governmental structure, talk a little bit about what they are, who does what, and also talk about some issues of implementation. So as with many things with attorneys, there is a disclaimer. I am an attorney. I'm a licensed attorney in the state of South Carolina, but importantly, I am not your attorney. Today's presentation is for educational purposes only, and if you have questions about how accreditation and Domain 6 affect your laws and your practice day-to-day in the health department, please consult your attorney. I've been in this field for almost 20 years now, and I know many of your attorneys at the state level, and they are quite excellent and great sources of information, and some of them may even be on the phone today with us. So I encourage you to reach out to them if you haven't already and get to know them, because they are the experts on your state laws and how you can use them for accreditation, and certainly how you can use them in your day-to-day. practice. So let's talk about today's presentation. We'll talk a little bit about who has the power to shape public health laws and public health policy in this country, a little bit about how that power and authority is expressed, and finally a little bit about public health law in action, and talk a little bit about memorandums of understanding and data use agreements, and from my vantage point, the increase in the use of those as we implement our public health programs around the country, especially in light of Public Health 3.0 and accreditation standards. So who has the power to shape policy that impacts public health? Really, we have to talk about the larger governmental structure in the U.S., and we think about this in the law as federalism. This really has to do with the division of power among the federal level, the state level, and the local level. And then, of course, in public health, we also have to consider the other jurisdictions in the tribal nations and also in the territories. And all of this is a complicated matrix of authorities and levels of government. But really, it's interesting if you look at the U.S. Constitution, it really doesn't say anything about public health. And oftentimes people wonder, why does public health look the way it looks in the U.S., with the federal government involved with some things, and state involved with some things, and tribes involved with others, and locals having some authority as well. And it really has to do with this idea of divided power amongst levels of government. When the U.S. Constitution was formed, states were really giving up authority to the federal government. Things like creating armies and coining money. The states had those authorities before the Constitution, and they gave those up. But one of the things that was not given up in this process was this idea of the police powers. The police powers were a set of authorities that actually dated back to colonial times, really having to do with promoting the public health, safety, and general well-being of the community. And states were doing this at the time we formed the Constitution. States were doing this by enacting and enforcing laws for the general welfare in order to take care of our common interests and promote health and well-being. And it really has to do with the idea of regulating private rights for the public interest. We certainly recognize individual rights in the U.S. As notably expressed in the Bill of Rights. But sometimes we need to regulate certain rights and property rights and interests to serve the public interest. So you might require someone to get a retail food establishment permit in order to operate a restaurant, because we want folks to operate at a certain standard so that they don't make the public ill in the preparation and service of food. One thing that we always need to keep in mind is the idea of tribal sovereignty. Native American tribes have a special status in the United States. They have their own set of powers and the ability to govern themselves to a significant extent, what we call tribal sovereignty, really based on the starting point that tribes have cultural sovereignty. And that cultural sovereignty and tribal sovereignty have been set in place through a series of laws and treaties dating back to the 1800s and through the 20th century. But importantly for us in public health, the tribes have their own authority to pass public health laws. That could then be, information about those could be submitted through domain in satisfaction of domain 6. So always need to keep in mind that tribes are their own nations and have their own public health authorities that they can express through their own legal structures for Indian country. And really what it comes down to is, the states, tribes, localities, territories really have the primary responsibility for public health in the U.S. In passing what we commonly think of in kind of a shorthand. And Robyn touched on this a little bit. We tend to talk about laws as this kind of monolithic thing. What do we mean by laws? What's included when we talk about laws, both topically and then also in terms of of mechanism. What are we using to express law? And really topically from a public health lawyer's perspective, a public health law is really kind of any law, regulation, statute, ordinance that has important consequences for the health of a defined population. So we look at a defined population within a jurisdiction. If there's some sort of statute, regulation, ordinance that has health consequences for that population, that to us is considered to be a public health law. It is not necessarily limited to laws that have to do with sort of the official health department, right? There are many other laws that affect health. Sometimes we intend for laws to affect public health. Sometimes we don't necessarily intend for them to affect public health, but in fact they do affect public health. So when we look at what state, local, and tribal governments can do, we see some of the traditional issues such as investigate disease outbreaks, right? We want government to do this to protect the populace, and we would generally recognize this. Most folks would say, oh yeah, that's a public health law. It's the public health department going out and accessing medical records and doing an epidemiological study of an outbreak to figure out what is making people sick. And I think in Domain 6 and with accreditation, many folks just go right to those sorts of laws to submit. But in fact, public health laws have a much broader scope. Jurisdictions can ban smoking in multi-unit housing. That is a public health law. It has a health consequence for a defined population. We can use zoning laws to create farmers markets, to deal with food deserts in urban areas. So zoning laws in certain circumstances can be considered public health laws, and as Robyn mentioned earlier, could be submitted as part of a Domain 6 package. To require kids to wear helmets on bicycles. There's many different ways. We could even pass transportation laws that open up bike lanes like the family's riding on. So transportation laws, even though ostensibly we're not passing them with a health impact in mind, they can have health impacts and then be considered a public health law. Essentially, when we look at public health laws, we're looking at the type of government and societal actions that really affect the bottom of what many of you recognize here as the pyramid, Dr. Frieden's pyramid, having to do with public health interventions. And at the top, we're really looking at interventions that focus on individuals, education, clinical interventions. And public health laws really exist at the bottom of the pyramid. We can use public health laws to change the context to make individual default decisions easier. And we particularly use laws, again, whether it's intentional or not, we use laws to affect people's socioeconomic situation and socioeconomic factors in our communities. And we know through research that the bottom of this pyramid is to a large extent where people's health is determined. We're really talking about the social determinants of health in these bottom tiers of the pyramid. So I get asked quite often, why would I as a lawyer be talking about the social determinants of health? And if you look at the map here, we're looking at a highway in California that crosses through several counties. And the reality in the U.S., if you go just a few exits on an interstate or some other road in the U.S., you travel a few miles, you can see dramatic differences in life expectancies. And what I like to say is, this is not the flu causing these differences in life expectancy. This really is the social determinants of health in action. And what we understand as attorneys is most of the social determinants of health actually have a layer of law below them. Law is determining those social determinants of health. And what we're understanding now in the public health law community is we can study law as a factor in the cause, distribution, and prevention of disease and injury. We can study law as a social determinant of health. And Domain 6, in the way it's structured, provides a perfect opportunity to show health departments studying law as a social determinant of health. So how is that expressed through our legal systems? What are the types of laws that are out there? First and foremost, of course, we have statutes. Statutes are passed by legislative bodies. We can also talk about ordinances at the local level. But they have several functions. One, they express the intent of the legislative branch, whether it's a state legislature or a city or a county council. They create and empower executive agencies. They regulate various activities, provide agencies authority to promulgate regulations and oversee regulated activities. We use statutes to appropriate money through appropriation bills. And what most people look at is we certainly use statutes to make certain things crimes. Regulations are also laws, and many regulations are public health laws. We really use regulations to flesh out the details of a statutory framework. Many times we're trying to regulate activities that legislatures don't necessarily have expertise in, and so they'll pass a broad statute. Health Department, you shall create an immunization information system. It may not be much more specific than that, and they're relying on a health department to pass rules and regulations to flesh that out and create a realistic system for tracking immunizations around the state. They tend to be much more detailed than statutes, and they're really where we start to see executive agencies, including health departments, start to implement the intent of the legislature. And they really have to do with implementation and enforcement, and are important in our public health law community. Also at the executive level, we can have executive orders that stand as another body of public health law. Executive orders can be used to implement a statutory code, could be used to implement regulations, and oftentimes are used, they may be issued by governors to direct executive agencies to enforce laws in a certain way or implement laws in a certain way. It may be that a particular administration is interested in focusing on health equity or health in all policies, and they could use an executive order to direct the executive agencies under the purview of a governor to implement laws in a certain way, and could very well be relevant to a package submitted under Domain 6 to show compliance with Domain 6. This is a super broad overview of public health law. If you're interested in more information, there's the Public Health Law Academy. It's publichealthlawacademy.org. We have a series of trainings that can be used to learn more about, go into much greater detail about the constitutional structure, statutes, regulations, case law, even if you're interested, specific domains on topics such as preemption. These are on-demand, interactive trainings that go through the CDC train system, and you could learn a lot more about public health law through the Public Health Law Academy, something we're very proud of here at CDC. So a little bit about really public health law in action. Sometimes the issue becomes, well, I need to get this thing done. How do I get it done? We see an increasing use of memorandums of understanding to collaborate across agencies and to build partnerships. And then, of course, in the increasing use of data and the importance of data in Public Health 3.0, an increasing use of data use agreements. So talk a little bit about those. Memorandums of understanding, they're not particularly complicated. They are written agreements that outline relationship between or among multiple parties. They kind of have a basic structure. They identify collaborators. They describe a purpose for collaborating. They outline parties' roles and responsibilities, who's going to do what, under what circumstances. And they can be used both as a planning document and a relationship building mechanism, And they're really more about that than some sort of binding legal document. I tend to think of memorandums of understanding as self-executing. Partners are kind of exchanging agreement to do things for each other. And if one doesn't do the other, then the other one's not on the hook for doing something. They're not necessarily a contract that you would take to court, but they're much more planning documents and relationship building documents. The benefits of using memorandums of understanding, they certainly can be used to strengthen coordination between a non-traditional public health collaborators. So if you're interested in moving into work on the social determinants of health, you might want to partner with your Department of Housing or your Department of Transportation. These agencies are not necessarily traditional public health partners. In an MOU and the process that you use to create an MOU can help identify strengths in different partners. And there's a lot of negotiation and back and forth and communication that allow partners to combine resources. We can identify similarities and differences in resources. And what's really nice is it provides an opportunity to create a common language around trying to achieve positive health outcomes. And ultimately, they are good for building relationships, because if you want to do an MOU, you've got to talk to people. You've got to email, you've got to make phone calls, and you've got to meet face-to-face to figure out what the document's going to say. They do have common attributes. Again, a description of the parties involved, purpose, context, background information is really important for MOUs. You're going to have a scope of services in there, roles and responsibilities, who's going to do what. This is true for data use agreements as well, including content transfer, storage, permitted uses, and lifespan of the data that you're talking about. And of course, there are always terms and conditions, the boilerplate that goes into agreements. These tend to talk about the mechanics of the agreement. So when does it start? When does it stop? How do you maintain records? Things like this. And sometimes these terms and conditions can also be in there just because federal, state, local, tribal, territorial law will require some terms to be in these. So one version of MOUs is a data use agreement. It's just a subspecies of a memorandum of agreement or a memorandum of understanding. And you really use data use agreements or DUAs to obtain access to data. You can use DUAs to constrain the use of data after it's released or after it's disclosed, to say, yes, I am willing to give you data for a particular purpose, but I don't want you to use it for another purpose. And that can be spelled out in a DUA, certainly including prohibitions on additional disclosures in the DUA. And you can also use it to ensure that rights and obligations are maintained. You have a standard to go back to and talk to partners about their use of data that you may release. Circumstances in which to consider the use of a data use agreement. Really, if you want to disclose data, it's probably a good idea, and I encourage you to speak to your attorneys. If you want to release data from your health department, even to a partner, even as part of something that's leading up to accreditation, it's probably a good idea to use a data use agreement. Most of the time we want to be concerned about future use of data, of subsequent disclosure, and there could be circumstances where the law requires you to use a data use agreement to release data from your health department. And it can also be used when you anticipate a future need to obtain data quickly. You can use the DUA to establish, again, this idea, we use agreements to establish relationships between parties. And a DUA can be useful if you anticipate a need in the future to get access to information quickly. Say, if you have a large hospital system and you're regularly interacting with them on disease investigations, a DUA can be useful to not provide you authority to access the records, because you probably already have that at the state level, but just to work out the details. Who am I going to call? what is your electronic health record system like? Am I going to have a user access to your electronic health record system? To facilitate quick access to information, DUAs can be quite useful. But it's also important to keep in mind that data use agreements are not required for every disclosure between all parties. So again, great to get with your attorney. I encourage you to take them out to lunch and get to know them, and they can help you with these considerations. So, the big question, why do we pay attention to the law? It is certainly part of the 10 essential services. It's part of accreditation process for a health department. But as Bill Fagey says, the first tool of public health is epidemiology, and the second tool might well be the law. And as Montrese Ransom here at CDC loves to say, there is no governmental public health without the law. If we don't have laws to create executive agencies and to give them authorities and powers to do things to better the public health, we don't have governmental public health without the laws. And they're an important component of our day-to-day public health practice in the U.S. So with that, turn it back over and move on to the next presenter. Thank you so much.
Great. Thank you so much, Matthew. That was some very, very helpful introductory information around public health laws. And now I'm excited to turn it over to the Utah Department of Public Health, who will now talk a bit to how they've actually implemented all of this into practice and become an accredited health department, and discussing Utah's story on roles and responsibilities for Domain 6. That I'll turn it over to Dr. Mark Babbit and Nikki Campbell. Thank you.
Well, first of all, thank you for inviting us to participate. I guess we'll go to the first slide there. And so some things that we want to share with you, and they're going to be pretty basic, but clearly all of you, and we sure do have outstanding staff, and they all need to understand that this is important to us. From the executive director's office down, we made it clear that we were going to do this, and it was our desire and expectation that everybody would assist as needed. And lots of communication that way. I have told folks that I felt part of my job is to be a facilitator, to help things happen, because a lot of the work is done by the frontline people. I think everybody knows this too, but it's pretty critical you have someone, an accreditation coordinator, who really will take the lead on the nitty-gritty stuff. As I was told, we submitted 10,000 pages of information to do the documentation for accreditation. So somebody's got to track all those kind of things and keep that on with that, and that was important. But as the slide says, it isn't one person. It does take the whole department and people willing to step up. I think when we got into the actual accreditation, there are probably over 50 people who are actually involved in some way or another in doing that kind of thing. I think it's important that you are, as you are going through the accreditation process, looking at the different domains, including the laws, are these things aligned with what you're trying to do as a department? And we'll talk a lot about our department's strategic plan and how it related to our statewide health improvement plan, and how it related to what we were doing with accreditation, because that was important to us. Clearly, as a state, we have to look with local health departments. In Utah, we don't have county health departments. We have, I think, 4 that are single county health departments. Most of them are multi-county health departments. So we work with our local health departments, and they're critical partners with us at every step of the way in doing these things. The other thing that I was asked to talk about was a little bit about our governing entities. I think, do we have another slide that goes on to that, I think? So we sort of have 2 governing entities that relate to us in the health department. The first one, the HAC, so Health Advisory Council. This is in statute that we will have a Health Advisory Council. It was kind of quiet, and as noted, they kind of got it going again back in 2002, which was before I came to the health department. But this is a group of people that are appointed by the governor. Quite honestly, most of the recommendations or nominations come from us to the governor to appoint people. Some key points, as you can see, is that it has to be a variety of people, but more than half cannot be health professionals. So over half have to be non-health professionals. And that's actually very useful, because these folks are a sounding board for our programs. We meet with them quarterly. We have a chance to present some of our major programs and seek their feedback. We have a chance to ask them if they are aware of things we should be doing that we're not doing. We obviously make them aware of key things that we're doing, such as our statewide health needs assessment, our statewide health improvement plan, what we're doing in performance management, and again, what we're doing with our strategic plan. Those are all things we want to share with them and get feedback on that. And again, the executive director is the lead person to relate to them, although if he can't do it, then that's my job to meet with them on this quarterly basis. And then the executive director will, report back to the governor on what is going on with the Health Advisory Council, what they're doing. I would emphasize, I think it's a good thing for us, but they are advisory. They don't have any statutory authority. They don't make laws or rules, but they do give us advice, and like any good advice, you can accept it, modify it, or ignore it. So we do all three at times. Our other main governing body is actually the governor's office, so I'm sure like most of the other states that your executive director is likely appointed by your governor. I don't know if that's everywhere or not. So we have a close relationship. We're very fortunate with our current executive director in that he is very close to the governor. He was working for 32 years as the local county health officer in the county where our governor is from, and the governor was at one time a commissioner there, which oversaw their local health department. So these two have a very close long-term relationship, and that's very good for us. Likewise, we work closely with the lieutenant governor and also on some of the lieutenant governor's subcommittees. And the governor's chief of staff is someone we've worked very closely with and have a good relationship with him. And I know we were really pleased that the chief of staff would come and be involved in our accreditation visit and meet with people when they came here. We also work with the Governor's Office of Management and Budget. I don't know what they're called in other states, but I'm sure you will have something similar. As we go through the budgeting process, we obviously have to go through and meet with people in the Governor's office to decide what the Governor's priorities are, what things he'd like us to be doing if he has priorities. We have to share with the Governor what our possible priorities are to make sure that they would support that in terms of funding, especially if it's new funding. So we have a very close relationship in that way. Also, the Governor's Office of Management and Budget in our state is doing something called a success initiative, where they're actually working with programs to see what we can do to really improve our efficiency. So many of our programs have had a very direct relationship with the Governor's Office to work on these kind of projects. So both those things have really helped us. And governing members of the Governor's Office of Management and Budget also came with our accreditation visit. It was very helpful to have people at that level come and be here when we had our site visit. And both governing entities, the HAC and the GOMB, are very interested in our strategic plan, and what we're doing with our priorities and what our statewide health improvement plan is, things like that. So those are all important to them. I think I'm going to turn it now over to Nikki to talk about some other issues.
Hey there. So just like Dr. Babbit's mentioned, it was of high importance to us not only to choose the right outside influencers for this domain, but also the right team within the Utah Department of Health. We had two co-leads. Having the legislative liaison who was appointed by our governor as one of the co-leads was invaluable. Our site visitors mentioned that it was apparent her influence on this domain, so I would really encourage anybody who has a legislative liaison who could help out with this domain to do so, because it was so helpful. Having someone from the environmental epidemiology program was also helpful, which is my program, so I'll go into that in a little bit. Our health department leadership team was completely invaluable to this process. Even though Dr. Babbit says that he was our facilitator, he truly was our champion, and our executive director is a self-proclaimed cheerleader to this process, but he was also a fellow champion. Having both of these individuals on our team to support us and the work we were doing made a huge difference, not only to boost our morale, but to CC on emails that hadn't been responded to lend their expertise and to promote our cause. Effectively got buy-in from the entire department, and there actually wasn't any Utah Department of Health employees that I met who were not aware that we were seeking accreditation, and that was really helpful to the process just to have our leadership buy-in. Of course, we couldn't have done this process without our accreditation coordinator. She was there to make sure that we were set up for success. She provided much-needed technical assistance, and she was just as much a part of our team as any of the others listed here. One of the most crucial parts of the success for our domain, I think, was having the support of our subject matter experts. They were who really took us to the next level. Like Robyn was talking about, kind of gave us ideas that were outside of the box, moving beyond just the traditional seatbelt, car seat, and TB quarantine examples. There are three specific examples that I want to talk about with you guys briefly. So we utilized the environmental epidemiology program. One, on the assessment side, we have an MOU in place with the Utah Department of Environmental Quality, who we worked with on harmful algal blooms, including the use of their authority, our executive director's authority in combination with the environmental quality to protect health by shutting down a lake that had a harmful algal bloom, for air emissions violations and water quality enforcement. As Matthew went over, having these MOUs in place was a huge advantage for us because even though we weren't the ones actually conducting the enforcement activities, we had those agreements in place with those who did, and they were actively using our services in their enforcement activities and their follow-up. Another program within environmental epidemiology that we used was the Environmental Sanitation Program. They review Utah State Public Health Rule every 5 years, and they modify as needed. They utilize subcommittees that consist of local environmental health officers and health departments, industry, as well as the public to better inform the rules that they modify or create. They're able to do that through public health rule through statute, or they're able to modify and create public health rule through the statute. Through this process, they're able to look at emerging trends such as food trucks, body art, and microblading, and create appropriate rule that is protective of health. So that definitely enabled us to provide more exciting examples like what Robyn mentioned. So at the time of accreditation, when I came onto the team, I was new and I was trying to think of people we could collaborate with and get examples from. And the first program that came to mind was the tobacco program because I was trying to think of somebody who wouldn't be too annoyed if I was asking for examples. But in addition to being some of the friendliest people in the department, it turns out they were working on some really exciting new things with e-cigarette enforcement and tobacco 21 proposals. So because they are one of the only programs in the department that conduct enforcement, their documentation was extremely organized and complete, making tobacco one of our strongest example areas. So if you do have a program within your department that is indeed conducting enforcement activities, of course, they would be excellent SMEs for you. And the last example I want to share was with the Early Hearing and Detection Intervention Program. In 2013, House Bill 81 in Utah was passed, which required all newborns to be tested for cytomegalovirus, which can cause lifelong eye, brain, and ear damage. We had an audiologist here at the Utah Department of Health who was doing amazing work around communications, education, and the enforcement of this rule. So we recruited her to our team, and that was another really fun example that we were able to share in our accreditation process. Without our subject matter experts, we probably would have had pretty lame examples and failed our site visits. They were key players in the process, and we definitely couldn't have done it without them. I think having strong subject matter experts on your site is definitely critical in the process.
So thank you, Nikki. And you can see Nikki has some really good concrete examples for you. I think that probably more helpful than my comments. But again, I just want to emphasize the importance of staff who are motivated and interested and able to do that, and they'll be your subject matter experts. We have a variety of stakeholders that really helped us. That did include our local health departments, but also we have a major healthcare system in Utah called Intermountain Healthcare, which actually has involvement with over half of the population in terms of insurance and healthcare, and they have been a partner all along, which has been very useful. We work with our tribes. There are 8 tribes in Utah. We have a single-person office who does that, but she's really excellent, has great relationship with all the tribal governments, and so they've been involved. And we have a monthly meeting of a Utah Indian Health Advisory Board that can provide us information and feedback. The attorneys for the health department are assigned to us from the Attorney General's office. They're quite excellent, and we use them very regularly, and they really work hard to support us, and they are real helpful to do that, and they played a role in this process. More, I want to call it a consultative role as opposed to as much of a direct role in doing the work. We had some legislators who were quite interested in what we were doing and wanted to know about the process. They weren't involved in the actual accreditation visits, but they still were interested in what we were doing, and of course they're critical to us with regards to budgets or policies or statutes. And sometimes when we write regulations, they want to review them with us. Something called Administrative Rules Committee, I think that they ask us to meet with them on that. And the other thing, which is just a huge thing, we got to have a mock site visit. I think maybe we'll ask Nikki or Jamie to talk more about that. But we were able, through a grant, to do a mock site visit that was done in June, and our full accreditation site visit was in September. But this was a huge success for us. We learned so much about what we could do right and what we did wrong and how to prepare for that everybody, the staff really felt like they knew what to expect the next time. From leadership, we knew what kind of things we needed to maybe do a little training on or discussion. For the SMEs, that really was helpful for them. So a mock site visit, I would say, is a must. If you really want to have the best chance of passing on the first time around, please try to do a mock site visit because it was really helpful. And I think with that, I better stop and turn it back to Jamie, I guess, and then we'll go from there.
Yeah, Jamie, if you have anything else to add to the mock site visit process, I bet people would be interested. It was just so helpful for us to have you guys.
Great. Thank you so much, Nikki and Dr. Babbit. We really appreciate that. So for those that are interested in a possible mock site visit for Public Health Accreditation, that's a resource that ASCO provides where we will be able to actually go out on site and conduct that some very similar site visit as you would receive from PHAB itself after you apply for accreditation. And that is a resource and an opportunity that we have available to state and territorial health departments. So if folks are interested in more information, I'm happy to share that, and we can connect after the webinar. And also want to send a big thank you to Dr. Babbit and Nikki for sharing kind of a bit about their strategies to working on public health laws in Domain 6 in Utah. And now with that, we do have some time for some questions. And again, want to take a moment to thank not only Dr. Babbit, Nikki, but Robyn and Matthew for such a fantastic webinar that was very, very informative. I do have a few questions that I've received from folks on the line already. If you have others for any of our presenters or all of them, please feel free to use the Q&A chat box feature, and I'm happy to moderate those. So with that, I'll go ahead and ask the first question, and this is for Robyn at PHAB. So Robyn, we have a question that I'm a public health lawyer. How do I know if my work aligns with accreditation expectations and the requirements of PHAB?
That's a huge question. How do you know if it aligns with PHAB? I mean, the standards and measures and the requirements in the standards and measures, that is it. So those are what the health department needs to provide evidence that they're in conformity with. So there's no other document or set of Q&As that you need to look at also. So if you're looking at the standards and measures, that's your guidance as to whether what you do fits with PHAB or not. And then as you're looking at the standards and measures, if you have questions about, well what is this requirement really getting at? What's the intent here? Or I could interpret it this way, or I could interpret it that way. That's when you contact PHAB, and you can email me directly with your question, and I'll get back to you in a matter of days. So I don't know. I'm not sure if I really answered your question because it was such a broad question. I hope that's helpful.
Great, thank you, Robyn. Yes, a broad question, but I think that was perfect advice to really point to the standards and measures to make sure that everything is aligned for that. Thank you. All right, our next question is for Utah. So how did you go about educating your state legislature about accreditation? So that's the first question. And then the second question is, what strategies did you take to get them involved throughout the process? So I guess the first question is, how did you communicate accreditation and inform your state legislature about accreditation and educate them on the requirements? And then after that, what strategies did you take to keep them involved throughout the process? So Dr. Babbit or Nikki?
Yeah, so this is Mark Babbit. So let me be clear, the whole legislature was not involved in the process. So we had some key people, especially, for example, the chairs of our Appropriations Committee legislature. They were aware that we were doing this and what was going on. I think we had some of the leaders of our Health and Human Services Committee legislature to be aware this was going on, what we were doing, and be available to answer questions and be updated. But that was the folks that were the key. We wanted them to be aware. It was interesting. They weren't coming to us and ask, how's it going, what's going on. We would be updating them occasionally. So in many ways, our legislature was kind of peripheral to this, but we never involved the whole legislature. I think the most, I guess maybe at the most, is when Dr. Miner, when we got our accreditation, I think he tried to make a very broad announcement to everybody that we were accredited. And at that point, I imagine most legislators were informed that we had accomplished it, but they weren't involved in the process.
Great, thank you. Do you have any specific tips or tricks that you all use to keep your maybe not just the state legislature, but others external to the health department involved throughout the process for Domain 6 and updating, working through public health laws, updating and revising them? That others might be able to take advantage of in their state.
Well, so this is Mark Babbit again. Really, I mean, so many of our programs, and Nikki mentioned in tobacco, she mentioned environmental health, she mentioned our early hearing program, but numerous programs are working with stakeholders all the time. And for the most part, the stakeholders were aware of what was going on with accreditation. And in this particular case, if it was about laws or rules or things, especially the ones that Nikki mentioned that were going to be used as examples for accreditation, I think the stakeholders for the most part were well aware this was going on and that they'd be part of it. Let's see if I remember, we actually had a handful of stakeholders, not very many, who came to the accreditation site visit. So we had a few. I have to ask Nikki, did we have them in Domain 6, stakeholders come to the site visit for that?
Not in Domain 6, but I know that they were present for other ones.
Definitely for the statewide health improvement plan and that kind of thing, I know.
It was definitely helpful to have their support.
Great. Thank you so much, Utah. I have another question for Robyn. So Robyn, this one is, you stated that there were 2 health departments that did not achieve accreditation. What happened to them as a result of not achieving the status? They also shared that we are hopeful, but in the back of our mind are worried about the outcome of the quote-unquote failure. So can you fill in the information about what happens to a health department if they do not achieve accreditation initially?
Sure. Well, first, let me make sure that everyone understands that PHAB accreditation is voluntary. So there are funding incentives from CDC and other funders, but there's no negative consequence of not being accredited. It's a voluntary program. And secondly, PHAB wants health departments to be successful. And the way that the process and the standards and measures themselves were designed was so that health departments going through the process and applying the standards and measures to their health department, that just going through the process, they would improve their performance and improve their quality of their performance. So PHAB is not in the position that, it's a gotcha process. It's not about that at all. We work with health departments through the process to ensure that they are accredited. And the process has several steps in it where if just for example, if a health department's assessment goes to the committee that makes the final decision, and the committee says, we can't accredit this health department at this time based on the assessments of its documents, then there's a whole step in there where the health department can submit an action plan that's then approved by the committee, and then they have up to a year to implement the action plan. So when you look at the numbers of 220 accredited health departments and 2 not accredited, the process is designed for health departments to be successful. Now that doesn't mean that it's easy, and I would say maybe that it's good that you have in the back of your mind that you're worried so that you take it seriously. and that you're careful about the documentation that you submit and the narratives that you develop to explain the documentation. But our objective is not to not accredit health departments. Our objective is that health departments are successful and that they improve through the entire process.
Thank you so much, Robyn. And I believe this next question is for you also, a general question around accreditation. So on average, how long does the accreditation process take, and what are some major factors that might make this the process last longer or go faster?
Sure. I would break that into two different phases. And the first phase is the phase where you're preparing for accreditation before you actually apply. And I've heard health departments say that it took them 2 or 3 years to go through the standards and measures, to develop their community health improvement plan and their strategic plan and make sure that it's all linked with the community health assessment. That, that just preparing for accreditation and doing a self-assessment around the standards and measures and making sure that you have the major pieces like the workforce development plan and the QI plan. Make sure that you have those major pieces in place. Can easily take 2, 3, in some cases even 4 years. Once you apply, it really does depend on the length of time that it takes to get accredited from when you apply. I believe is absolutely connected to the amount of time that the health department took before it applied to prepare for the application and prepare its documentations. So if the health department didn't take those 2 or 3 or maybe 4 years to prepare for accreditation, and it submits documentation that is really off the mark or is confusing to the site visitors, it's going to take the site visitors more time to review it, have more questions, which then the health department has to take more time to get those questions answered. The site visit can be difficult because the site visitors, the reviewers, are having trouble understanding it. And then if it gets to that point where the committee is deciding whether it's accredited or not, if it's not accredited, then it goes through that action plan process, which is part of the process. It's not a negative thing, but it does take longer. It can take up to a year longer. And then some health departments do ask for extensions for some steps if there's something that has happened in their community that's beyond their control. Maybe they've had an outbreak or a flood. They can ask for an extension. So from the application to when they receive accreditation can be a long time, but I would say a lot of that is in the hands of the health department and how much preparation they did before they applied. So I hope that that's helpful.
Jamie, could I add to that?
Yes, please.
It's Mark Babbit again from Utah. So just simple answer from time. It took us about 2 years to gather all the documents and everything to put it together to actually have it all submitted. From the time they closed our book, so to speak, on the documentation, we had it was 7 months before our mock site visit, and it was another 3 months till we actually had the official site visit, and ended up being about a full year from the time they closed our file, so to speak, till we got the official announcement that we were accredited. But the one point I would like to make, that I think the most difficult stumbling block for us has to do with how things are documented. So we do lots of things. I'm sure every health department listening in does lots of things and lots of great things. The question is, do you write it down? Do you date it? Is it on a piece of paper that has your health department logo on it? It's stamped. That's where we had a problem because, as you know, everything in accreditation in the beginning is all written documentation. Everything is going to be judged by what's written. And if you don't have things that are written that are actually, again, dated and on letterhead or things that show that it was official, you can't count it, you can't submit it. So I would say a lot of the challenge we had the first time around was making sure we found good examples where it would meet that criteria of being dated, having who was attendees at it, what the vote was if there was a vote, and so on and so forth. And I can tell you that after the accreditation was done, when we talked to our staff and congratulated them and thanked them, we said, and please, from now on, at every meeting you have, please take minutes to write down the attendees. Please put it on official letterhead of some kind, and as you put it in your file. So when we come around in a couple of years, start to do this again, it'll be a lot easier to do that. So that'd be my biggest bit of advice to people.
That is great. Thank you, Dr. Babbit, for sharing that. All right, and I actually don't have any more questions queued up, so I sent one more final reminder. If you all have any final questions for Robyn, Matthew, or the Utah team, please feel free to use the chat box to ask those questions. And I will take this time to also remind folks that this is just webinar 1 of a 3-part series focused on PHAB Domain 6, and so still a lot to learn from these other 2 webinars. On May 9th at 2 p.m. Eastern Daylight Time, we'll hear from the New Mexico Department of Health as well as Washington State Board of Health on updating public health laws for PHAB accreditation. And then for webinar 3 on May 23rd, it's enforcing and providing education on public health laws for PHAB accreditation. And more information can be found on ASCO's website for that. And I have a couple of questions in the queue now. Thank you for sending those. We have an individual asking if somebody, so maybe Robyn or even Utah, if you all can answer this, but asking someone to summarize some of the benefits of accreditation.
Sure. Oh, go ahead. Please go ahead.
Oh, okay. For me, as Dr. Babbit's mentioned, ever since we became accredited or began the process, all of our notes have become super organized. They now have the UDOH logo on them, which is really helpful for grant applications or when we send things other places. I personally work for a grant program, and we are asked on the application if we are an accredited health department. So I imagine in the future other grant applications will be doing the same, and it is so nice to be able to mark the yes box instead of the no. Those are the first ones that come to mind. I'm sitting here with other subject matter experts, so maybe others will come to mind as well. But Robyn, you go ahead and we can chime in.
Sure, okay. We do regular evaluations with health departments through the process and at the end of the process, and we send a survey. I think it's a year out after health departments have been accredited. And so there are some sort of softer benefits that I think are very important. Health departments report that they've improved their performance through the process, and that they're more effective after having received accreditation. We hear from a lot of health departments that the whole process was really helpful in terms of developing an internal team among the staff of the health department, that now staff knew how what they did fit into the whole department, and they had a better sense of what other health department employees were doing, but also working with the community, that the standards and measures require community collaboration throughout. It's a theme that's sort of woven throughout the 12 domains. And so health departments report that they work much better with other organizations in their community and with community members. And there's more transparency and understanding. And with that collaboration in the community, the health department can really extend its reach in terms of being an effective public health department, because it doesn't have to do it all by itself. It can get a lot done by working with other organizations. So those are two sort of less quantifiable benefits, but we hear it all the time from health departments.
I agree with Robyn that the culture around PHAB, even though it sounds intimidating at first, is very much in the spirit of improvement, and we have felt that, and it's been apparent ever since. One other thing that came to mind was that accreditation gives every program or individual a time to shine, and really you can inform others, even within your department and other places, of things that you're doing. And I think people really enjoyed being able to do that. So that was a really fun aspect of it. And then I have a bureau director here in the room, and she has a comment as well.
Thanks, Vicki. I was one of the SMEs for this domain, and I guess I would say across looking at all of the domains, I really just feel like accreditation helped unify us as a department. Like Nikki said, we got to know other programs and appreciate what they were working on. And with our partners, they were better able to understand things that we were working on as well and appreciate the process. But another benefit I would say is that it also helped us identify areas that we can improve upon in a collaborative way. And I know one thing that we really came out to us was the need to work on health disparities in a more unified way. And we knew programs were doing that kind of on their own, but now we have an opportunity to work on it more collectively and have a better impact. So it's just helpful to identify those areas where we can improve as well.
Thank you, Robyn and Utah folks, for that. And I have a question for Matthew. Matthew, what resources do you know of that are available for health agencies to learn from other states about successful updates to laws or proposed laws, or just general resources for states that are wanting to be more involved in the public health law process?
That's a great question. As far as active updates to laws, I think it's helpful. There's quite a few organizations out there that collect laws. One is my group, the Public Health Law Program. We do technical assistance for health departments around the country at the state, tribal, local, and territorial level. So if you have a domain of interest, you're interested in zoning laws or any of the laws that we talked about, any kind of public health law, and you want to know what states are up to in those areas, you can contact us directly. There's another group that we work with quite closely at Temple University on policy surveillance program. They run a website called Law Atlas. Law Atlas has legal data sets up that explore laws, so you can look at, say, what do laws across the 50 states say on return to play for athletes that may have suffered a concussion, and a great IT system that sort of helps you navigate those laws. Change Lab Solutions is another organization out in California that collects information on laws. The Network for Public Health Law is another partner organization of ours that does great work. So there are many organizations that sort of operate at a national level that can help point you in the direction of laws that you're interested in. And we all kind of know each other and work together. And if you're asking about a particular domain that somebody doesn't know quite as much about, they can point you in the right direction and get you to the experts that would be helpful. Of course, your associations, ASCO and NACHO, also have folks available who can help as well, and we work with them as well. So feel free to reach out to me directly. I think we may have contact info through the slides here potentially, but anything you want to know about public health laws around the country, either we can help you directly or get you with the folks that know more than we do.
Great. Thank you so much, Matthew. And yeah, he did mention ASCO on there. So ASCO does have a legislative tracking, does do legislative tracking and provide technical assistance upon request as well. So if you are interested in that, please feel free to reach out to me. All right, we just have a few more minutes, but I do have one other question for Robyn. So Robyn, if the preference is for examples involving the social determinants of health, many, if not most, are outside of the authority of traditional public health. How should those be reflected in the application?
You're absolutely right. Many of those activities and programs are outside of the authority of a traditional public health. So the whole key is partnerships and collaboration. So if the health department wants to improve physical activity, it's traditionally the health department would try to educate the population about the need for physical activity. But with social determinants of health and the various determinants of health, doing that may involve working, now this is a local health department example, but working with Parks and Rec to have more bike paths, or to encourage, have an area, maybe if it's a town that is along a river, have stations of different exercises that people can do. The whole issue is to change the environment so that the environment creates health. And that means that the health department, they are unable to do it on their own. The health department has to work collaboratively and cooperatively and through partnerships. So how that manifests itself in documentation is that it shows that there's a partnership there. So PHAB says to health departments, you don't have to lead a particular process, but you need to show PHAB that you're intimately and actively involved. So if you have documentation that perhaps was developed by a partner agency or some other kind of organization that shows that you're doing that together, and you have documentation of meetings and maybe an MOU and a list of partnership members that lists the health department, you can use that documentation. It doesn't have to all come from something created by the health department, and in fact it should not be. We're looking at documentation and how the health department works with its partners and its collaborators in the community, at the state level, with other state organizations and other state agencies. I hope that helps.
Thank you so much, Robyn. We have time for one more question, and this one is directed towards the Utah team. So how did Utah select the subject matter experts for the domain team?
That's a great question. So like I said, I was brand new when I came onto this team. So for me personally, I was thinking, like, who do I know and who is friendly and who's not going to be annoyed, to be honest. But also, once you put the examples together, you're looking at who can speak to these examples, specifically for Domain 6, to the enforcement side. We had mostly program managers or like bureau director level people in our session for our site visit, because they were really the ones who knew what was going on. But if you have people who are boots on the ground doing the enforcement or out in the communities, then absolutely you should choose them as a subject matter expert. In your site visit, we were told that any document or example is fair game. So whoever can speak to whatever examples that you submitted is who you would probably want as your subject matter expert. For Domain 6, we did have the largest group for the site visit, and I think we had about 15 to 20 people in the room with us, and that was just fine.
Great, thank you so much, Nikki. All right, we are out of time for questions, and I want to again thank each and every one of our presenters for spending the afternoon with us, as well as our funders for supporting this work, and of course the participants that joined this robust discussion and the great questions that we had at the very end. So thank you all for that too. I did want to quickly just ask you all again to please take a few minutes to complete the evaluation at the conclusion of this webinar. And I hope that you'll all be able to join us on May 9th for the upcoming public health law for updating public health laws for PHAB Accreditation, part 2 of this webinar series. And again, all of these slides will be included in the follow-up webinar email, so you should have access to those immediately, and the webinar recording will be made available within the next week. And I want to thank you all for joining us. And that concludes today's Domain 6, Introduction to Public Health Laws for PHAB Accreditation webinar. And thank you all.